students, we are discussing pleural diseases, and we have discussed pleurisy in the last class. Today we can move on to pleural effusion. The collection of fluid in the pleural space is called pleural effusion. Just inflammation of pleura can be termed as pleuris. That is the first phase of inflammation. So in a single disease itself, at the first phase there will be pleurisy, and can move on to pleural effusion in the next phase as the pathology advances or the disease progress. Then regarding the fluid content, usually there is some fluid in the pleural space, and it's usually 25 to 30 ml of fluid, and it can vary up to 100 ml also. And the fluid is formed at the parietal pleura, and it is absorbed through visceral pleura. And various factors involved in the maintenance of this particular volume of pleural fluid, and this include hydrostatic pressure, then plasma osmotic pressure, and also capillary permeability. All these factors help to maintain the pleural fluid volume inside the pleura. In certain conditions, in disease conditions involving the lungs or other organs like heart or kidneys or even liver, or in some infections, this balance can be disrupted, leading to accumulation of fluid in the pleural cavity, leading to a condition called pleural effusion. This plasma, the factors include plasma osmotic pressure, hydrostatic pressure, and capillary permeability. This plasma osmotic pressure is derived from proteins and colloids, and which hinder the movements of fluid out into the pericapillary area. That is the plasma osmotic pressure. Then hydrostatic pressure, it is 9 centimeter of water in the parietal pleura, and 10 centimeter of water pressure in the visceral pleura. And this favors the movement of protein-free fluid from parietal to visceral. Because of this pressure difference, that is 9 centimeter of water pressure in the parietal pleura and 10 centimeter of water pressure in the visceral pleura, and because of this pressure difference, there is movement of protein-free fluid from parietal pleura to visceral pleura. And the third factor is capillary permeability. Normally, healthy capillaries permit very little protein to leak into the vascular space, but in disease state, the permeability is increased, and large amount of fluid and protein may filter into the pleural space. So these are the factors which maintain the pleural fluid dynamics, that is plasma osmotic pressure, hydrostatic pressure, and capillary permeability. And there is a driving filtration force from the parietal pleura into the pleural space, and it is estimated that about 5 to 10 liters of protein-free fluid is formed or filtered into the pleural space in 24 hours. So in about 24 hours, about 5 to 10 liters of pleural fluid is formed in the pleural cavity, but almost 99% of the fluid is reabsorbed. So the fluid is formed in the parietal layer and is absorbed from the visceral layer, and various factors involved in the balance of this volume of fluid. Okay, so that's about the formation of pleural fluid. Then if there is increase in the volume of fluid, or when there is effusion, the condition becomes more serious. And we can classify pleural fluids. We have to classify pleural effusion based on the nature of fluid or nature of effusion. And we can classify pleural effusion into four. That is serous effusion or serous exudate, then purulent effusion, hemorrhagic effusion, and opalescent effusion. So there are four types of fluid or four types of effusion basically. First of all, serous effusion, purulent effusion, hemorrhagic effusion, and opalescent effusion. Then we can go into details of each and every fluid. First of all, serous effusion. And you have studied effusions or serous effusion in detail in pathology classes. We can classify serous Xrayed serous secretions into two, that is transudate and exudate. Transudate and exudate. And there are few important points differentiating between transudate and exudate. First of all, transudate, and there is transudate in the pleural cavity. Then the effusion is called hydrothorax. And the features of transudate include, first of all, the specific gravity. That's one point differentiating between transudate and exudate. In transudate, the specific gravity is between 1008 and 1012. In case of exudate, the specific gravity is more than 1012 or more than 1016. When it is above 1016, then definitely it is Xrayed. Then regarding the protein content also, the protein content is less than 3 gram per deciliter in case of transudate and is greater than 3 gram per deciliter in exudate. So the protein content is also important. It is less in transudate and is more in exudate. That is less than 3 gram per deciliter in transudate and more than 3 gram per deciliter in exudate. Then it does not clot. Transudate does not clot, but exudate usually clots. So the clotting property is also important. Then regarding the color also, it is very pale or pale yellow color in transudate, but yellow to brown in case of Xrayed. Then on examination, on microscopy examination, we can find only a endothelial cell or few endothelial cells are seen in case of transudate. But when we do microscopic examination of Xrayed, we can see a variety of cells. Different types of cells are there, like lymphocytes, eosinophils, mesothelial cells, malignant cells, fungal elements, multinucleated giant cells, LE cells, etc. Different types of cells you may get in Xrayed, but you will get only endothelial cells. Few endothelial cells are seen in transudate. So these are the basic difference between transudate and Xrayed. So the first classification, type of fluid is serous Xrayed. So serous Xrayed can be divided into transudate and Xrayed. And which are the conditions leading to this transudate? And here also there are number of conditions, and there is overlap of conditions also. And transudate is formed in conditions like congestive heart failure, then constrictive pericarditis, thrombosis of superior vena cava obstruction, thrombosis of esophagus vein, hypoalbuminemia, liver cirrhosis, nephrotic syndrome, then peritoneal dialysis, then acute atelectasis, etc. Or idiopathic causes are also there in case of transudate, formation of transudate. Then Xrayed, a lot of conditions coming under Xrayed formation. The most important condition is tuberculosis, then pneumonia, malignancy, infarction, abscess formation, bronchiectasis, fungal diseases, then traumatosis for pneumothorax, then neoplasms, various neoplasm, primary CA, then metastatic CA, leukemia, Kaposi sarcoma. Then abdominal conditions like after abdominal surgery, amoebic liver abscess, pancreatitis, carcinoma of stomach, etc. Then systemic diseases like SLE, polyarteritis nodosa, then Jogger syndrome, fungal diseases, asbestos, occupational lung disease, mainly asbestosis, etc. All these conditions, sarcoidosis, all this can lead to formation of Xrayed in the pleural cavity. So these are the different conditions coming under serous effusion. So serous effusion can be divided into transient and Xrayed. Then the next type of fluid is purulent effusion. Purulent effusion, that is, it's otherwise called empyema. Empyema. I will write it. It's otherwise called purulent effusion or empyema. Empyema. We have studied emphysema, that is dilatation of air spaces, emphysema. Here, this is empyema, that is purulent effusion or pus in the pleural cavity. So it's basically pus. The translate or Xrayed can be changed into purulent effusion. And depending upon the character of pus in the pleural cavity, we can differentiate few conditions. For example, in pneumococcal infection, the color is thick greenish yellow with thick flakes of fibrin. Flakes of fibrin are also seen in case of purulent effusion. Then in case of streptococcal effusion, it is the pleural fluid is thin, turbid, and greenish in color. So we can differentiate between pneumococcal infection and staphylococcal infection just by looking the just by noting the appearance, color or the color. Then this purulent effusion is seen in bronchiectasis, lung abscess, actinomycosis, penetrating wounds of the chest when there is chest injuries, then bronchopleural fistula, that is connection between the air passages and pleural cavity. Bronchopleural fistula. This can happen in pneumothorax also. Then subphrenic abscess, rupture of esophagus, then hematogenous spread from other side, that is pyemia or septicemia. All this can lead to pus in the pleural cavity or purulent effusion or empyema. So that's the second variety, purulent effusion. And third category is hemorrhagic effusion or blood inside pleural cavity. And three type of presentation can be there, that is blood tinged Xray, just traces of blood in the pleural fluid, or secondly there can be frank blood in the pleural cavity, and the third presentation is chocolate colored fluid in the pleural cavity. Blood tinged Xrayed, first of all, blood tinged Xrayed is seen in neoplasms, contusions, infarction, tuberculosis, anticoagulant therapy, hemophilia, etc. Then frank blood or large quantity of blood is seen in pure blood is seen in traumatothorax. Then hemorrhage from tumor implant. Then spontaneous pneumothorax. All these conditions that can be frank blood in the pleural cavity. Then chocolate color is due to degenerating RBC or disintegrating RBC. It is usually seen in amoebic liver abscess rupturing into pleural cavity. And the amoebic liver abscess rupture into the pleural cavity, or when there is presence of old cholesterol effusion, we will get this peculiar color or chocolate color. It's called chocolate colored fluid you get in pleural cavity. That's about hemorrhagic fluid. Then the last type of fluid you get in pleural effusion is opalescent fluid. or chyly or milky fluid. It is otherwise called chylothorax. CHYLO, chylothorax. This is called chylothorax. That's the fourth variety. It is due to presence of lymph in the pleural cavity. It is due to rupture of thoracic duct following trauma, then tuberculosis, parasitic infections like filariasis, then thrombus of left subclavian vein. In all these conditions, we can find presence of lymph in the pleural cavity. So that's about the features of pleural effusion and classification of pleural effusion depending upon the nature of fluid. So I will repeat the nature of fluid which can differentiate pleural effusion, that is serous effusion, purulent effusion, hemorrhagic effusion, and opalescent effusion. Then we can move on to the symptoms of pleural effusion.